Hello and welcome to the LEAPcast. In this episode, we speak to Professor Daniel Gartner from Cardiff University. Daniel is Co-Investigator and Lead for Cardiff University for the LEAP Digital Health Hub and is Chair of Operational Research at Cardiff University School of Mathematics. His research interests are in mathematical modelling applied to healthcare improvement, and we spoke to Daniel about a project he was involved in using maths to figure out what are the smallest changes that can lead to the biggest improvements in ambulance wait times. Imagine you fractured your hip. You've gone to your local hospital, but they've identified that you need more specialist care. You need an ambulance to take you from where you are to where you are going. Your family is waiting with you and the clock is advancing. The ambulance requests are building up and day turns into night.
So imagine you're a patient, you're waking up in that situation that you're transported at 11 o'clock in the evening. Is it safe that you wake up then, or that you arrive at 1 o'clock in the morning in your new hospital? That is sometimes,
That's certainly not very fun.
Exactly.
Moving patients between hospitals and specialist care facilities is a routine but critical part of healthcare. Delays affect patients, families, and staff. Overnight transfers, in particular, can be stressful and undesirable and are not what the overnight infrastructure is designed for. This so-called intersite transport is also a cornerstone of what we call value-based healthcare. Value-based healthcare acknowledges the fact that the NHS has a finite amount of resources and asks, how can we deliver the best patient care given the resources available? It focuses on outcomes that actually matter to patients. So instead of just asking how many treatments did we deliver or how many patients did we see, it measures things like, did we improve quality of life? Did we improve patient symptoms? And did we do that while using resources efficiently? Ultimately, did we do it in a way that benefits the greatest number of people? It's one of the things in the NHS that is probably a bigger economic burden than people realise. The NHS spends around £460 million annually on these activities, and they are incredibly important to patient well-being.
So an intersite transport that is needed when you are a patient in one of your local general hospital. And when you're waiting for your, for example, broken hip or leg or something that can't be fixed immediately in that hospital, so you'll have to be transported into a specialist critical care center that is in the middle of that hub and spoke network.
So when you say hub and spoke, can you explain that a little bit?
So you have local general hospital outside as your point of contact where you go with your minor injuries, and then if that turns out, we need to really look into detail, there needs to be specialist care for that, then you would go into the center in that hub, into that hub hospital. And it can also go the other way around with the transport, that you're in the critical care center in the middle and you need a step-down transport, that your prostate surgery, for example, that has been carried out, a specialist surgery, you can recover then in your local general hospital, closer to home. That's where you would then need a step-down transfer.
So why are patients waiting? An obvious explanation might be that there just aren't enough ambulances.
There were actually enough ambulances, but they were actually in the wrong place at the wrong time, as you could
interesting. This is where the maths happens. What Daniel's team did was use operations research. Operations research is the application of scientific methods, mathematical models, and analytical techniques to support decision-making in a way that improves the performance of complex systems. Operations researchers use data science, systems thinking, and maths to build evidence for making better operational decisions.
So that was a little bit about, like a Rubik's Cube, the red and the blue and the yellow bricks are just at the wrong place. So you need to kind of rejig that cube so that everything is in place again. The demand and the capacity are aligned correctly, rather than having too many ambulances in the early morning hours, whereas most ambulances are needed in the afternoon.
Operations research tries to understand complex systems through data. As a data person myself, I'm super interested in how you get the the data, and what does that look like? What do you have?
Yeah, usually you haven't got that integrated data system where you have all the shift schedules in one system and all the breaks and all the different demands of a step up or step down or step across transfer and the times and the traffic, etc. So all these data sources need to be joined or linked up with one another. But yeah, we approached Welsh Ambulance where they could send us their staffing patterns and their requests and demand. And then we also had from the wards the different demands. So all these data was then linked. And of course, we saw some patterns that had weekday dependent requirements or weekday dependent demand. So on some days of the week, you have more transports of this type or the other type. And then also during the day, some transports are more likely to be in the morning hours or in the afternoon hour.
Modelling is a simplified representation of reality that helps us explore what might happen if we make different decisions. It's basically a decision support tool that asks what if over and over and over again, allowing us to explore a huge number of scenarios and see what would happen without having to make those changes in the real world and potentially impact real patients. You can think of it a bit like a game of Tetris. There are lots of different pieces of different shapes and sizes. Those pieces might represent the number of patients, the distance you have to travel, the length of an ambulance shift, or when the shift starts. So the question becomes, how can we best fit those Tetris pieces together?
But then you have, like a Tetris puzzle that you have these long shifts and these shorter shifts and the breaks in these shifts that you have to align with the capacity. So all puzzling is going on in the background when you solve a model that is, underpinning that exercise.
This is where the maths can help us try out a number of different combinations that simply wouldn't be possible in real life.
You have all these different bricks available and the different squares or L bricks or this different shapes and forms. And now they have to be put into that shape actually to mimic that demand. So that's where we used a famous mathematical model that is called a set covering model. And the set covering model tries to find only the amount of bricks that are really necessary to mimic that demand curve. So imagine a demand curve that is starting in the morning to be relatively, having relatively small demand, and then it picks up in the late morning hours until in the afternoon that flattens out then, because then in the afternoon, evening hours, not a lot of ambulances then are needed anymore, or not a lot of transports are needed. And then when you try to mimic that demand curve, then you have only these and those types of bricks basically available that you put on top of one another. And that's where the optimization bit or a solver in Excel, there is an open solver and an Excel solver available that can do that for you automatically. So that is then formulated algebraically with different constraints and an objective function. And we call them decision variables. So that basically tries out so many combinations then and mimics that demand curve.
But the challenge isn't finding a mathematical answer. It's finding an answer that works in practice. One problem with operations research is that it rarely makes it to real life. Researchers build mathematical models that ask questions like, what if we did this? What if we did that? Would it improve clinical care? But that work rarely makes it into frontline practice. The models often exist as journal articles, but they don't include implementation details, and they don't navigate conflicting stakeholder objectives, and they don't consider what is needed to get end-to-end user buy-in. This was the case at the Aneurin Bevan University Health Board, centred around the Grange University Hospital Hub and its surrounding general hospital spokes. The network was facing chronic transfer delays. This was caused by a profound misalignment between demand and capacity. What that means is that during periods of high demand, there simply weren't enough free ambulances. On the face of it, it might seem that adding more ambulances would be the answer. So what's different about Daniel's study compared with what has gone before? There has been quite a lot of previous research on ambulance deployment, but historically it has prioritised location and relocation problems over the human element, things like shift scheduling, meal breaks, and workforce constraints. Meal breaks, for example, are standard contractual requirements, but many previous scheduling models treat capacity during a shift as continuous. This means assumptions about availability are overly optimistic and ignore the fact that there will be periods during a shift when a crew member is unavailable because they're on a break. Daniel's group developed a scheduling model that explicitly included shifts and mandatory break windows, effectively dovetailing mathematical optimization with operational practice. In other words, they combined theoretical maths with real-world reality.
So what was really surprising for me is that the initial mathematical model was not really what the ask was for at the end. So at the end of the project, you're wiser than at the beginning, because at the beginning, we just wanted to find out what is the minimum coverage of ambulances needed. But then it turned out that the mathematical model was spitting out too many ambulances. So we had to really reject everything, reformulate the objective of the model, reformulate constraints that were too much binding, too constrained in the model. So we had to relax these things and those things. You could say, okay, in that 15-minute period, for example, you may accept that one less ambulance is okay, is fine, as long as that demand is then roll over to the next period where you have a little bit more ambulances available. So flexibility issues like that were then incorporated into the model. And this was a big learning experience for the whole team, for all of us, which was also exciting, and which was a learning then for next projects going on, like really talking to the customer or to the client or to the manager. Is that really what we want to optimize for? Is really the minimum ambulances a goal, or is that maximizing the or minimizing the gap between demand and capacity? Is that a criterion to optimize? So things like that were happening during the project, and big learning experiences for us.
A really important requirement was balancing the different needs of multiple stakeholders, because if you ignore any particular group, you're likely to end up with an unworkable solution that is destined to fail. A key stakeholder group is, of course, the patients. The goal is to minimize waiting times and unmet demand, those periods when demand exceeds availability, while still being able to deal with emergencies. You also need to take management into account. The aim is to minimize the total number of contracted ambulances to save money, while maintaining standards of care. Then you need to think about ambulance workers. The model must contain specific constraints that reflect reality. A day shift is 11 hours, an overnight shift is 10 hours. Staff require an unpaid 30-minute meal break between 3 and 5 hours into a shift, followed by another 20-minute break in the second half of the shift. The model needs to account for all these factors, otherwise it will not translate into the real world.
The learning then for next projects going on, like really talking to the customer or to the client or to the manager. Is that really what we want to optimize for? Is really the minimum ambulances a goal, or minimizing the gap between demand and capacity? Is that a criterion to optimize? So things like that were happening during the project, and big learning experiences for us. Yeah.
And it sounds like you've learned a lot as a team, and you've learned a lot from each other. Is it quite unusual to have this sort of relationship? Is it normal for mathematical modelers to be working so closely with hospitals?
When you look into the academic literature, there is not a lot happening in terms of demonstrating the impact, which is sometimes quoted as a missing engagement bit. That sure, you did the modeling exercise with your immersion department, etc. You create a simulation model, but then at the end of the paper, you're missing that bit of, okay, so what? Did it make a difference? Yes or no? So that's where often in academic literature, there's a shortage a little bit of these successes basically in implementation.
A really important thing they did was adjust shift start times to track peak demand while maintaining 10 peak time ambulances. They then used the model to run several scenarios and identify the most optimized staffing arrangement without increasing the number of ambulances.
In the post-modeling phase, basically, when we were asking then about the new contract arrangement between the Welsh Ambulance Service and the Cardiff University Health Board organization, how could these new ambulance schedules be rolled out, and how can we make a change having several ambulances starting at the same time in the morning versus a more staggered approach? that had to then include unions and discussions between Welsh Ambulance and the Bevan Health Board. So things like that happened. And then obviously not everyone was then happening with change. And that had to be then go back and included in the model. Yeah, so things like that were happening then after the kind of modeling phase where we went into implementation. So it is the long shifts, short shifts, morning shifts, night shifts, 2 breaks in shifts, only 1 break in the shift. Is it a long break or a short break? Is it, like I said, like a very long shift that goes like more than 10 hours, and then you can't have, for example, an ambulance starting at weird hours in the morning, 2:00 in the morning. There's nobody who would be available to go into the hospital at 2:00. So you would have to make sure that an ambulance starts with a shift at latest in the evening. I think 10:00 we had, and then not earlier than 6:00 in the mornings, things like that. So all these constraints would then be formulated and then put into a model. And then sometimes it happens that the schedule is unfeasible because you don't have enough ambulances, or you don't have, or the shift patterns, they are not doable. Or you have too few Lego bricks of that type, but you would need them to accommodate demand of that type.
Once the model had been implemented, the most surprising finding was that they were actually able to reduce the number of ambulances from 10 to 7 and use smarter scheduling to cope with the reduction. Weirdly, the reduction in resources led to the best performance. Mean delay times fell to 87 minutes, and for the first time ever, the system reached a new zone of quality control, with 1 hour and 4 hour target compliance rising to 83%, exceeding the 80% national benchmark.
It was very interesting because it turned out that there were enough ambulances available, but we should just rejig them and stagger them rather than having them like multiple ambulances at the same time, etc. So this was making, so we were able to demonstrate that, and we were even able to demonstrate that with a slight decrease in number of ambulances, we can still reduce the waiting times for transports and the overnight transfers. But when you implement that, you do all the modeling exercise, data science bits, etc. When it comes to the implementation, then it's a different thing, because you have all these metrics that you have in terms of the improvement side. So you track then how many overnight transfers happen, what is your waiting time for a step up transfer, what is the waiting time for a step down transfer or step across transfer. So all these things are then measured continuously. And so you do that before the actual implementation, after the actual implementation, and then you see really excitingly how that drop in waiting time happens and how that drop in overnight transfers happen with improvement methodology that has been done in the Institute for Healthcare Improvement in Boston. And there's really improvement science behind that. So then we were able to put a p-value, like a statistical significant improvement to it. So this was then showing the executives then, this actually helped them to make a difference and make an impact.
This optimization resulted in a realized cost saving of approximately 1.1 million in the 2024-25 financial year. What this study showed and what was demonstrated through implementation in Aneurin and Bevan is that aligning supply and demand is a more powerful lever for improvement than simply adding resources. The instinctive response to transfer delays is to increase the number of ambulances. However, these models showed that smarter scheduling delivers better value for money. So what do the authors think was the secret to their success? Something they called true co-production, not just maths, but involving frontline staff and managers in the modelling process. By considering shift constraints and operational realities, they made sure the solution was workable in the real world. The model respected ambulance workers' contractual start time preferences and break windows, which helped prevent the staff resistance often associated with top-down roster changes. Could this approach help the NHS beyond ambulances?
So there are so many optimization bits in terms of where mathematical modeling can be used to understand gaps in demand and capacity. When you're planning for winter pressures, do you have enough beds, for example? So that is happening every year. Do we have enough intensive care beds? And then how long would queues be if beds were, if we had 5% more beds or so and so many less beds? What happens with operating theater capacity? Do we have, so that is a classical scheduling problem where master surgical schedules are created. So does a department like trauma and orthopedics department, gynecology, urology, etc., do they have enough capacity in theater 1, 2, 3 in that day of the week, while the surgeon is away on a Friday, but only 2 sessions or 1 session on a Monday, etc.? So all this kind of puzzling or jigsaw puzzle to solve is a classical operational research or mathematical modeling technique. So these things are happening, or the geographical modeling. Do we have enough GP practices in area X, Y, and Z, subject to waiting times can't exceed so and so much? Do we have enough lung capacity or lung function doctors in that part of the country? Things like that are classical examples.
The spreadable innovation identified in the study is already being scaled locally to optimize chemotherapy and hematology scheduling at the Royal Gwent and Neville Hall hospitals, where clinical leads aim to reduce treatment burdens and maximize daily patient throughput. Ultimately, this research demonstrates that sustaining high-value healthcare requires embedding analytics directly into organizational culture and operational management. Well, thank you so much for joining us today. It's been really interesting,
welcome.
and I'm very excited to hear what happens next.
Great, thanks for your interest.